right, go ahead, Jason.
Cool, thanks. So like I was saying, just nebulizers, pretty much it breaks down your liquid form of medication into a mist, small droplets. So what we're saying is that you have, when you're talking about your jet nebulizers, it's pretty much you have your compressor hooked up to a tubing, and then you have your medication in this canister. So just a canister here, and all it does is like this compressed gas pretty much turns that medication into aerosol soft mist that the patient can breathe. So that's the whole concept between a pneumatic nebulizer. Ultrasonic nebulizers actually, pretty much the basic concept is still pretty much the same. You have a high frequency generator over here that pretty much causes vibration to a piezoelectric crystal. So a piezoelectric crystal is pretty much a crystal that can take a mechanical injury and make it electrical. So it converts this pressure, this ultrasonic pressure, into this kind of energy, and that electric energy then starts to vaporize your medication that's in here into a mist kind of form, aerolized mist form that the patient can actually breathe. So it's more efficient than your jet. It's less bulky. You can actually they have some that you can actually take around with you. And then our mesh nebulizers. Our mesh nebulizers is pretty much, it just has a mesh with a lot of holes in it, up to 1,000 to 7,000 depending on the manufacturer. It's on top of the liquid, and it just pretty much vibrates, and it creates an aerolized mist in the same kind of form. So one thing about this is it's highly efficient. You can take actually a lot more medication with a mesh nebulizer than you can with all the other nebulizers that they have on the market. Also, it's very portable. So they have a lot of portable mesh nebulizers on the market that you can actually take with you. So those are the three types of nebulizers that they have right now. So Respimat. I know we hear a lot about Respimat, but mostly in more Europe, they actually are really trying to convert a lot of their stuff to Respimat. So Respimat is a soft mist inhaler. It pretty much lasts in the air. So one of the concepts is so you turn it around and then you're able to spray, and then you get this soft mist that just comes up into the air. And the whole point of that is that you decrease the velocity that you had when we was talking about the PMDIs. So you decrease the velocity. It helps with decreasing velocity in a soft mist kind of form for you to inhale more than medication than was one of the supposed limitations with the MDIs. It actually did. It was a small. Actually did a small study. Actually, it was only 12 patients, but then they just looked at the deposition of the medication using a Respimat, an MDI, and an MDI with a spacer. The Respimat had about a 40% distribution into the lungs, as opposed to an MDI, which just had 15%, and an MDI with a spacer, which had around 30%. So I was saying that the Respimat had higher efficacy of course, having more of the drug inside of your lungs as opposed to an MDI. Although with MDI with spacer was not too far behind, but like Dr. Moore was saying, that most of this can, if most of this, 50% of it was actually can still be into the lungs with time. One of the things that's limited to this is that this was led by the pharmaceutical companies, and on top of that, it was actually only 12 patients. So, but the concept is still that the Respimat actually tends to have more of the medication in your lungs just because of the decrease in the velocity.
And it's relatively slow.
Yeah, it's slow. So you don't have to worry as much about that situation inhalation with it, because it's pretty much coming up slow. It's decreased velocity and it's in a mist form, as opposed to the MDI, which you have an increase in velocity, and it's just kind of, they feel like just because of that increased velocity and the decrease in the velocity with the Respimat as opposed to MDI, you don't have as much oropharyngeal deposition of it as you have with the Respimat. So that's why the whole concept of it is that just because you have less velocity, less will actually deposit into your oropharynx area and more will deposit into your lungs.
Irrespective of the timing of your breath.
Irrespective, because Yeah, irrespective of the time of your breath, yes. So advantages and disadvantages of your nebulizers, of course. So your jet nebulizer, you don't have any issues with coordination and inhalation. It's more expensive than your MDIs. More time is required, of course. You can get contamination just because of the fact that you're dealing with a lot of tubing. You have to prepare it, so it requires a little bit more preparation for you to use your jet nebulizers. Your mesh nebulizers is faster. You get more accurate delivery of doses. It's portable, which is one of the big advantages of the mesh, but it's actually more expensive, which we talked about. And you don't have all medications that's available. And with your mesh nebulizer, your ultrasonic is also expensive. You have faster delivery. Coordination is also not required. MDIs, of course, is convenient. Almost all medications really come in MDIs. It's portable. Of course, one of the disadvantages that we talked about is the inhalation accentuation that we have with the MDIs. One of the limiting effects, and because of that, you have larger pharyngeal deposition. And then your DPIs, they're also, you have less inhalation coordination problems because you don't have to worry about that as much, but because of the fact that you need to have a good enough inspiratory effort, they're actually limited for people who require moderate to high inspiratory flows. So some of the disadvantages. So as we've seen this before, kind of our assessment of our COPD pharmacological therapy, and we're going to try to go through each step of these and why we use the medications that we use. This is another pretty much graph of saying the same thing. Short-acting beta agonists. So our short-acting beta agonists, they're pretty much G protein-cooped receptors. They're widely distributed in the lungs. Of course, they are in our airways, endothelial cells, mast cells, neutrophils. How they work is you have your beta agonist that will pretty much work on your beta agonist will work on this receptor, and this receptor will activate your G protein receptors, and then they'll activate your adenylate cyclase. Your adenylate cyclase will then convert your ATP into cyclic CMP. Your cyclic CMP actually works as a second messenger system. One of it works works on calcium influx. It actually decreases calcium influx. The other part of the cyclic GMP is to work on pKa. Both of these work in connection with each other to decrease the myosin activation. So when you decrease the myosin activation, you get bronchial smooth wall relaxation. So that's the whole premise of the beta receptors. What's the effect on therapy? So we know from studies that by working on that beta receptor, this is short acting, sorry, we improve symptoms as measured by the daily breathness scale, and we improve lung function. There was a study that was done in Europe that looked at just pretty much the FEV1, and it showed that it was a slight increase. So you have improvement of your symptoms, and we know that there's some reversibility. And this is in contrast to like asthma, because we know that this COPD actually has a reversibility pattern, and we can see that because we still see some effect by giving people beta agonists. So there is some let me not say reversibility, but there's some degree of reversibility that we can feel as far as we improve our symptoms, we improve our lung function. So that's the premise between.
I'm not disagreeing with you, but you have to be careful about the statement. And the reason is those kind of studies really depend on the population that they look at. And some of these studies will look at different populations. Some will look at people who have COPD as defined by non-reversible disease. And other groups will look at a real-world population where 30 to 40% of the COPD population that they're studying has reversible disease. So I think you're right in a global sense, but there's a lot of differences between the studies depending on how they're done.
Albuterol versus labialbuterol. These are two of the main medications we have for our short-acting beta agonists. Albuterol, of course, goes as provincial Betalin, and levoalbuterol goes as Xopenex. Onset of action is pretty quick, 5 to 10 minutes, and it peaks effect in an hour and a half later. Lasts 3 hours. Pretty much the difference between albuterol and levoalbuterol is that levoalbuterol, they're isomers, and albuterol is a racemic mixture. It has S-albuterol and R-albuterol. R-albuterol is levoalbuterol. And the whole concept is that as part of the albuterol, it's an inactive substance, but they do think that it does have some degree of reactivity, bronchial wall reactivity. So the accumulation of this, they think, can have a paradoxical effect and cause actually some vasospasms. So the whole concept was to make just a straight R-albuterol, which is Xopenex, and it should have an increase in efficacy with that. Also, because of the fact that you're not having to use so much to get the desired effect, one of the things that they used to market on Xopenex was that you have less tachycardia because you're using less medication. So the difference is really in the numbers. None of the studies that I looked at, I could find that there was any difference in outcome between Xopenex and albuterol. The only difference was the cost. One albuterol inhaler costs around $10, maybe $11. Xopenex costs around $50. Find this on the website. And I actually think it's more because my son actually has asthma, and actually they wrote a prescription for Xopenex, and I got a bill for $150. So yeah.
Well, no, yeah, that's wrong. Just the copay on an albuterol is now $15 to $20. That's
Okay.
after insurance pays for it. Everybody's still on the basic patent on the drug right now, so you'll never find one for $10.99.
Okay.
Yeah.
Maybe it was Canada.
That 1984 guy.
Yeah. Was that Canada? I'm sorry, I'm not sure. Yeah, but I know that I know Xopenex. I couldn't find the exact, but I know Xopenex when I got it from my son. It was actually.
See, actually, the Canadian picture on the right is because he has no access.
My whole point is it's just don't get fooled by the marketing that they're all drug dealers. They're all drug dealers at the end. Don't get fooled by the marketing. Long-acting beta agonists. So the ones that we have on the market right now is that we have our salmeterol, formoterol, Proviva, L-Capta, Vinerol, and Respimat. These are the ones that we have on here. This one is usually within, it's using a combination, so you don't actually see it alone. And pretty much, so we're on mostly Group B now. There are long-acting beta agonists, Group B, Group C, Group D. So the effects on therapy, and this is pretty much what we will see if we start acting on the long-acting beta agonists. We'll start seeing a decrease in exacerbation rates. We will see improved in lung functions, improve in quality of life, with decrease in our rescue inhaler, and also no increase in mortality. And that's the reason we put that in the end is because it's been shown to increase in mortality in asthmatic patients. So most of the trials, it was actually secondary endpoints that they looked at. So it wasn't actually a primary endpoint, but they did not see looking at those that there was any increase in mortality with using long-acting beta agonists. Our anticholinergics. Our anticholinergics play a pivotal role in our bronchial tree. The bulk of the anticholinergics are in airways. The bulk of the autonomic nerves are in the branches from the branches of the vagal nerve. You have your preganglionic fibers that enter the lung at the hilum and travel pretty much throughout the lungs. So that's their reach. So our cholinergic receptors, pretty much what we mostly work on for at least the lung are our M3 receptors. They work on pretty much the smooth muscles. Our nicotinic receptors are mostly preganglionic fibers, and they're not significantly affected by the anticholinergic medication that we have currently. So mechanism of action, pretty much we have our acetylcholine. Our acetylcholine works on our M3 receptors. After you have our acetylcholine work on our M3 receptors, we got a configuration change, increase in calcium, and the increase in calcium intracellularly causes vasoconstriction. So of course, by working on our M3 receptors, having anticholinergics will actually decrease this downstream vasoconstriction. So we're going to be talking about short-acting LAMA, so we're still going back to A.
I have a comment.
Yes, sir?
I've seen a question on boards where they asked about anticholinergic and whether or not they were selective for the different muscarinic receptors, and they are not.
Yeah, no, yeah, they're not.
Right, so.
They don't have any selective. They work on all, but it's the ones we're worried about. The ones we're looking at physiologically wise are our M3s. But yeah, they're.
Studying for board association, remember they're not selective.
So people studying for boards, not selective. So our short-acting anticholinergics. So we know. So what we have on for our short-acting anticholinergics is pretty much Atrovent, ipratropium. We know from studies that it improves lung function, improves symptoms, and increased tolerance. Although it was in the lung health study, they showed that that although it increased exercise tolerance, it was not statistically significant. So we think it improves exercise tolerance, but we know that it improves our lung function and our improved symptoms. So we're going to talk about our long-acting muscarinic antagonist. So our long-acting muscarinic antagonist, what we have on the market is Spiriva, Tudorza, am I saying that right? Tudorza, and Incruzalipta. Oh yeah, sorry. In most countries, Spiriva actually is administered as an SMI, but in the United States, most of our patients are on DPIs. And actually, look, we do have it actually on formulary that if you actually just put Respimat, you actually the tiotropium Spiriva actually will come up. But I don't think we mostly we just use DPIs. Yeah, it's more expensive. So the effects of our long-acting muscarinic antagonist from studies, we've shown that it actually reduces exacerbations. We have a decrease in reduction in lung decline when they was looking at the FEV1. Also an improved quality of life. And this was for patients with moderate to severe disease. And this was actually looked at, I was looking at a Cochrane database, and the last one they just had in 2014 actually showed this, all of these, a reduction in exacerbation, reduction in lung decline, and improvement in quality of life. So we've pretty much been able to hit most of our A, B, C, and some of the So our inhaled corticosteroids. So some of the ones that we have on the market are Flovent, Prevor, Pulmicort, and Alvasco.
Forgot mometasone. You forgot mometasone.
Oh, I forgot mometasone.
Xopenex.
That's true. So the pathophysiology between inhaled corticosteroids is because we know that COPD is an inflammatory process. The irritant in the form of smoke tends to cause increase in our T cells, our CD8 cells, as opposed to CD4 with asthma. We get increase in our neutrophils, we get increase in our macrophages. These actually start to release cytokines in the form of our interleukins, 1 through 8. We also have increase in our MMP, which is our metaprolase, and we also have increase in our TNF factors and fibrinogen. And that's so these are the consequences that we have from smoking. All this causes a cascade of symptoms that cause a cycle of inflammation. So we tend to get mucosal hypersecretion, alveolar wall destruction, and fibrosis by each of these inflammatory cascades. So the whole premise between inhaled corticosteroids was to decrease this inflammatory process. So the effects of therapy, we know that inhaled corticosteroids, from the studies, it improves symptoms and quality of life. It slows down, sorry, it's redundant. It slows down lung function decline and reduces frequency exacerbation. But one of the things that that you will notice from most of the studies that there was no impact on lung function or mortality. So it's not used as a sole therapy in COPD. Dysphonia. So one of the complications that we tend to see a lot of times in our clinic is that people tend to have hoarseness. How do we address this hoarseness, and what's the patho behind this? It's a common complaint. So it pretty much involves factors because we're giving them this inhaled corticosteroids. We can get myopathy of the laryngeal muscles, mucosal irritation, and because of the inhaled corticosteroids, they're prone to laryngeal candidiasis. All these are thought to play a role in forming dysphonia. Does anybody know what we usually do in our clinic for this?
Dysphonia is dose related. You can just decrease the dose and avoid it most times.
Actually, that's true. No, that's not. That is very, very true. And also, they said that you can decrease the dose. You can change it to DPIs because they felt as if DPIs you can have less deposition in your oropharynx area. And then you can also, if those two don't work, decreasing the doses or change it to a DPI, you can actually try to change it to Alvasco. And one of the reasons why we try to change it to Alvasco is that Alvasco is a pro compound. Cyclin-sonide is a pro compound, so it doesn't actually form its active compound until it reaches X-rays, which is in the lungs. So the whole premise between using Alvasco is that you're hoping that it won't have this pro drug until it reaches the lungs. So you have less deposition, you have less of the active compound in your oropharyngeal area. So hopefully you'll have less of the side effects of the hoarseness. So some of our combination therapy, we have Symbicort, which is budesonide and formoterol, Advair, which we know, Dulera, and Breo. So what are the effects of therapy when we use these combination? Lung function, we showed small reduction in lung decline, and this was from, of course, the TORCH study that we're all familiar with. Respiratory symptoms, mostly from a meta-analysis that showed decrease in the progression of respiratory syndromes just modestly, and mortality benefit, which was seen in the TORCH and the INSPIRE trial. And some of the common side effects that we already know of systemic, we're really just talking about the short-acting respiratory syndromes, rhinitis, pharyngitis, and tachycardic, of course, from your beta agonist. Or you're using the anticholinergics, so of course, most of the side effects for anticholinergics you'll get, which is like your nausea, diarrhea, your headaches. You can also get coughs. From your short-acting anticholinergics, bronchitis and sinusitis, and your long-acting, you can get constipation actually from your anticholinergics. And your corticosteroids, you can get respiratory tract infection, sinusitis, you can get candidiasis, throat infections. And these are my references.